Well, it's 11:01, so I think we might start for the morning. So thank you everyone for joining us this morning, and welcome to the Aboriginal Health and Medical Research Council e-cigarette webinar. Before we begin, I would like to acknowledge that I am hosting this webinar from Darawal country, and I would like to acknowledge the traditional custodians of the various lands on which you are all dialing in from today. I would like to pay my respects to elders past, present and emerging, and extend this to the Aboriginal and Torres Strait Islander people presenting and participating in this webinar. So we have Raglan Maddox and Professor Emily Banks with us today. Unfortunately, Professor Karma was unable to join us. He has some sorry business that he is attending today. So our thoughts and best wishes are with Tom and his family at this time. So Professor Emily Banks will be discussing e-cigarettes with us. Emily is an epidemiologist and public health physician. Her research uses large-scale population data to identify potentially modifiable factors affecting individual and population health in different settings to inform improvements in health and in healthcare. And Dr. Raglan Maddox is from the Modowa clan in Papua New Guinea and is the study director of tackling Indigenous smoking, the National Centre of Epidemiology and Public Health at the Australian National University. And Dr. Maddox will be talking about electronic nicotine delivery systems, specifically addressing Aboriginal, specifically addressing Aboriginal and Torres Strait Islander tobacco prevalence and significant declines among youth and young people. So we will have an opportunity to have questions be asked at the end. If you do have a question that pops to mind and you would like to put it in the question box or the chat box, please do feel free to do that. Otherwise, if you would like to wait until the end, and you can address Emily or Raglan yourself, and we will begin. I'll hand it over to you, Emily.
Thank you very much to Marina and the organisers for this opportunity. I'd like to start by acknowledging the traditional custodians of the land that I'm meeting on, the beautiful Ngunnawal and Ngambri country. I'd like to pay my respects to their elders past and present, and to all the Aboriginal and Torres Strait Islander people who are here today. And I'd like to thank you for the privilege of living on your lands and working in partnership on health. I'm here today to talk about the evidence on e-cigarettes and smoking behaviour and health outcomes. So to the next slide. So I'm going to start with a bit of background and talk a bit about the use of e-cigarettes in the community, and then ask the question about whether or not they help for quitting smoking, some of the risks, and what factors increase and reduce the risks related to e-cigarettes, and then a little bit about what this means for prescribing. I'm going to let you know that I am not a practicing clinician, although I did train in medicine. So I think I can provide broad guidance on that. But I think it is going to be important for organisations like the AH&MRC, but also the individual Aboriginal community-controlled health organisations to think about your own policies and what kind of guidance you want to be providing. Very happy to support with the evidence needs for that. So just flagging that that's the general context. So e-cigarettes, electronic cigarettes, vapes were invented around 2003, and they've been on the US and EU markets for around 15 years. There's a huge variety of devices and many thousands of chemical combinations. The actual number of products run into the hundreds of thousands. Basically, they consist of usually nicotine, which is in freebase or more recently salt form, and then it's in a kind of a vehicle, which is propylene glycol, vegetable glycerin, and then very frequently it has flavours in it. They're in a device that heats up this e-liquid made of those chemical combinations, and it's then converted into an aerosol that somebody inhales, and that delivers the nicotine and the flavours to them. The thing to also note is that these products are changing all the time. So it's a kind of a moving target. So if we think about the broad products, there were the initial, what we call cigalikes that looked like cigarettes, the smaller vape pens, these more powerful box mod products, which have a kind of computer inside them. And then more recently, these vape pods, which either include a little refillable thing you put in it, a cartridge or pod, or they're disposable. And these two, the vape pen and the box mod, generally you buy the e-liquid and you pour them into you've got a little dispenser, you pour them into a little reservoir in these devices. So there's a big variety, and here are just some examples. The vape pods in particular now look like little USB drives. They're very easily concealed, very popular with children. But they can even look like lipstick or just common household items. So in terms of the regulation, there's very wide variation internationally, ranging from absolutely no regulation at all to being banned. So in 33 countries, sale of nicotine e-cigarettes is banned. Australia is unique in that nicotine e-cigarettes are available only on prescription from a registered medical practitioner, and today is the day of the rollout of that law. So it's been illegal for quite some time at a state level, apart from South Australia, to possess and use e-cigarettes. But now there's been a loophole closed in the national law as from today. That means that it's legal nationally. It's important from a medical service point of view that this is not, they are not registered medical products. They are not on the register of therapeutic goods. So they haven't been through the TGA processes to establish their safety and effectiveness, and also the quality of the products. So, and because, and they're also not on the PBS, so they're not subsidised in any way. But people, doctors can become authorised prescribers, and that will then mean that they can issue a prescription, and the patient can get the prescription through a local supplier, through a pharmacy, or through what's called the person importation scheme. So this is the infographic from the TGA. So that there's the person who's either a smoker or an e-cigarette consumer consults with a doctor, they obtain the prescription, they can get it through the local supplier, or they can order it online and the overseas manufacturer or retailer will send it to them. Now this, having it through the person importation scheme actually means that some of the packaging requirements and other, like childproof packaging, are not required. So I will talk about the risks related to person importation. It's just important that have a kind of picture of what that looks like. So the other thing to note is that 36 countries regulate the concentration and volume of the nicotine in e-cigarettes. And I'll just give you these numbers now, but the upper limit in 35 of those 36 countries is 20 milligrams per mil. So you're not allowed to have any product greater than 20 milligrams per mil in those countries. And the EU limits their refill container sizes to 10 mils and the device tank sizes to 2 mils. Now, bear in mind that these countries have the e-cigarettes available as a consumer product. In Australia, under the prescription model, our upper limit is 100 milligrams per mil, and there's no volume limit, and there's also no limit on flavours. But what I mentioned is that there's no packaging and labelling requirements if products are brought in under person importation. So I will be talking a bit more, but 100 milligrams per mil and anything above 20 are high concentration products, and they are highly toxic if drunk. And they can, so we'll just get onto that from a safety point of view. So nicotine is one of the most addictive substances known. It's highly addictive, and the potentially lethal dose of nicotine is around 5 milligrams per kilo. So if you had that 100 milligrams per mil and you had a 10-kilo child, they would only have to drink half a mil of that to be potentially lethal. So the 100 milligram per mil bottles of liquid are really a very toxic thing. But for even the sort of 50 milligrams per mil, one swallow can be enough to really cause a lot of harm in a child. And there was a case in 2018 of baby J in Victoria where the mum had brought in high concentration product for their own mixing over personal importation, was mixing up the bottles to put in the device and turn their back, and the baby drank the liquid and died from it. So that's one example. It's very rare, but it's really important to bear in mind. So the dose that an individual receives relates to the nicotine concentration in the liquid to the device. So it really varies according to the device, and also the user behaviour, how many puffs they take, the depth and length of those puffs. We do know that these e-cigarettes can reduce cravings and nicotine withdrawal symptoms in smokers. And blood concentrations similar to or greater than smoking for nicotine are seen with products that are less than or equal to 20 milligrams per mil. At the moment, at the time when we did this review, there were no specific clinical guidelines. As of this week, we do have some guidelines from the RSCGP, but it's very difficult to actually have really clear guidance on the dose needed because there's so much variation in terms of the concentration of the device and the user behaviour. And in the National Health Service, they actually just say go to a specialist vape shop to get the information about what dosing device is right for you. What they do say is if you're talking about free-base nicotine, which is where the trial evidence is, then a light smoker should have around 3 milligrams per mil, a moderate smoker around 6 milligrams per mil, and a heavy smoker around 12 milligrams per mil. So you can see all of those concentrations are less than 20 milligrams per mil. If you're using the box mod, these big devices, they've got quite powerful heating coils in them and you need a lower concentration. If you're talking about the vape pens, they are less powerful and so you could use a higher concentration. But this is for free-base nicotine, so it's all under 20. This is just an example of what you can get over the internet. So this is 100 milligrams per mil, that's very strong, and I can get for $80 half a litre of it. So this is the cheapest way to do it. So, but you can see that what you then need to do is take that 100 mils, because you can't actually use it neat over 20 milligrams per mil. Anything over 20 milligrams per mil, you've got to dilute. So you've got to handle it at home, and they've said you need gloves and syringes and calculations. But also what you've got to do is take this concentrated liquid and put it into your special bottle, which has the propylene glycol. It's got the kind of vehicle or the kind of thing you dilute it with, as well as the flavours. And you've got to then say, well, what target strength am I going for? This is from the website of this organisation. But say I was going for a strength of 6 milligrams per mil, and I had a 60 ml bottle, I've got to put 3.6 mils of this 100 milligram per mil bottle. So it's pretty complicated. And it's going to be happening in the home. So that's just something to bear in mind if people are bringing in these high concentration products. So in terms, that's just a bit about the product. In terms of safety, I'm just talking about the use in general. So the e-cigarette use currently in Australia is 2/3 of it is not for quitting smoking. In Australia and Aboriginal and Torres Strait Islander people, we don't have a huge amount of data, but in 2018-19, around 8% reported having ever used an e-cigarette, and around 1.3% reported that they were a current user at least monthly. There's very limited data. If you look at the general population, it's pretty similar, 11% ever, 2% current use, and 1.1% daily use. But what's important to bear in mind is that around more than half of these current users are actually smoking at the same time. So they're actually using the e-cigarette in combination with their normal smoking. And quite often that's and when you ask people about that, that's quite often because e-cigarettes are cheaper, and also they can do it in places that they can't smoke, and it's more socially acceptable. So the most common pattern is actually what we call dual use, and we really don't know what that does, but it's not using it to quit smoking, basically. And around 16% of people who have never smoked, and quite clearly they're not using it to quit smoking either. There is increasing use among children and youth, and if we look at the age group 15 to 24, around 20% ever users and about a bit under 5% of current users. We see that same pattern for Aboriginal and Torres Strait Islander people. And uses in Aboriginal and Torres Strait Islander people, use is more common in the city than in the country. So do they help people to quit smoking? That's the first question. Well, we're really not sure. We did a systematic review of this, and there were 12 randomized trials, and the conclusion was there's limited evidence that they are effective for smoking cessation when you compare it to nicotine replacement or to no intervention or standard care. All of the trials are with free-base nicotine. There's no evidence about the newer nicotine salt products or the pods. The concentrations in the 2 trials that did show efficacy, the dose was less than 20 milligrams per mil. And in fact, it started off on average in the one we have most data from, it was about 10 milligrams per mil on the beginning and then 6 milligrams. So people were also, as they were using it, they were they were reducing the concentration over time. So we know that smoking has terrible impacts, and I know Raglan's going to be talking about this. One thing I think we need to talk about is that if we're talking about e-cigarette use in people who've never smoked, we should be comparing it to not smoking anything. You know what I mean? Quite often we're comparing e-cigarette use to smoking, which is the deadliest thing that we do. So it's really important to say that for when we're talking about use in the general population, we're really saying how do the health effects of e-cigarettes compared to if the health effects of not doing anything. With smokers, we need to think about it helping people to quit. One other thing is we know from our data that are major harms even from light smoking. So we're looking at about a 9-fold increased risk of lung cancer, even if you're smoking 1 to 3 cigarettes a day. So people might be saying they use e-cigarettes to cut down. It's really important that the goal is quitting, because prolonging that smoking is a real problem. So, so the other thing to look at too is that when we look at the main trial about quitting smoking, is we start off with 886 smokers, and they were randomised to nicotine e-cigarettes or to usual care. And what we found was 6 months later, around 18% had quit smoking. 4% had quit smoking and were not using e-cigarettes at all. 14% had quit smoking and were still using the e-cigarettes, so still using the nicotine. But 25% kept smoking and using e-cigarettes. So the other problem we have is when smokers use e-cigarettes, more of them go on to become what we call dual users than actually quit. And that's really important to bear in mind, that if we're trying to target this use, we need to think about using to help people switch entirely to e-cigarettes, not to have something that will keep them going with both smoking and e-cigarettes. So are they a gateway to smoking? Yes. So non-smokers who use e-cigarettes are about 3 times as likely to go on to smoke tobacco than non-smokers who don't use e-cigarettes. And there's strong evidence of this. So essentially with people who are non-smokers, the e-cigarettes are highly addictive. People have a nicotine addiction, and then they're more likely to go on to become smokers of cigarettes. And that's the evidence is particularly from young people. What are the other risks? So we have really very limited data. And one of the biggest problems we've got here is they've been around for about 15 years, but we don't know what they do to a lot of health outcomes. Now, some people say, oh, well, we don't know a lot. That sounds okay. But actually, if you think about tobacco and the harms of that, at first we didn't know what they did, and then a lot of people were hooked and we worked out what they did. So it's really important that we are cautious about things where we don't know the effects. So in terms of the risks that we have identified, these are largely sort of short-term and acute, because those have been the things that we can see. So we know that poisoning is a problem, including fatal poisonings, and we know that that can be accidental in children, but also it can be used for suicide, so for self-harm. There's toxicity, which is where people have inhaled the e-cigarette nicotine and they've inhaled too much. So that can cause seizures, and it can also cause cardiac arrest. And I was talking to the head of the emergency department at one of the big hospitals, and she said recently, oh, in the last 3 weeks, I've had one person come in, a young person who'd been inhaling e-cigarettes with seizures, so fitting. I've had another death by suicide that we attributed to drinking the e-liquid, and I've had a toddler come in with cardiac rhythm disturbances or arrhythmias. So it is happening here in Australia, and it's happening at the coalface. And I think one of the important things we need to do is to gather the evidence about that. They can cause injury and burns, because they have a battery in them. All of the devices have batteries in them. and you have a situation with a battery and you've got really a lot of heat. And so the US Fire Association estimates there's around 800 injuries from e-cigarettes every year in the US. We don't have estimates for Australia. We also know that they can cause lung injury. So there was a big outbreak of lung injury in the US, particularly with 2,800 people affected. Most of that was where there'd been a THC and vitamin E acetate added to the e-liquid, but we have seen it with people just using standard nicotine e-cigarettes. And bearing in mind they've got flavours in them and components that have been found to be safe to use in food, but we don't know their effects from inhaling them. We do know that they lead to addiction, and we know that there's a risk under the prescription model of diversion, that people will be prescribed them and then they'll give them to family or they'll sell them, that kind of thing. So there's a risk that what's prescribed will end up in the community. Another risk is use in non-smokers and dual use, and that increased uptake in smoking in non-smokers. The other thing is environmentally, they can create a lot of waste, particularly the disposable products, because they're just thrown away every few days. And then fires is another problem. So the injuries and burns also means you can have environmental fires. We really don't know the short and long-term risks. So we don't know for cardiovascular disease, cancer, mental health, development in children and adolescents, reproductive outcomes. So we don't know about what their effects are in pregnant women and their babies. So there's a big long list of what we don't know there. This is the nicotine salts and pods are a particular hazard. They make high concentration nicotine much more palatable. So people it stops them irritating their throat. So there's a limit to how much you can inhale with the free-base nicotine because it irritates your throat. But these products actually, particularly once the flavour's added, people can inhale very high concentrations. So if we look at the Juul brand in the US, they actually had a starting dose of 59 milligrams per mil, which is very high. And the puff bar, these disposable products are much more popular with children. They also allow very rapid delivery of nicotine, so really similar to a cigarette, and they look like a USB. And these are considered the major driver of a sort of youth e-cigarette epidemic in the US and Canada. So Canada had around 10% recent use in children and high school kids in 2016, 2017. In 2018, these pods were introduced. In 2018-19, they had 20% use. And they then brought in a rule of a limit of 20 milligrams per mil, specifically to address the pod problem. But I think from a public health point of view, obviously we've got the poisoning, but the use of these pods in kids is a real problem. And I was just outside my daughter's school. I collect the rubbish about the e-cigarette rubbish. And this was the first one I found. It's bubblegum flavoured. It's got lollies on the front. It's a very high concentration product, but it's also a very high volume product. And it's actually the equivalent of 9 packets of cigarettes in terms of nicotine, just this one pod. So it's really creating a real opportunity for these kids to be using a lot of nicotine. So this is my note about the personal importation scheme. So for products that are supplied in Australia through a community pharmacy, you have to have an ingredients list, you have to say what the nicotine concentration is, you have to have the warning statements, and you have to have child-resistant packaging. Those things are not required if they come in through the personal importation scheme. Now, most stuff that comes in through the personal importation scheme will be from countries that themselves require a child-resistant packaging, but you can't guarantee that. So it's a bit of a problem. So in terms of the prescribing and healthcare implications, the first thing, for people out there is that this is an unapproved product. So the balance of risks and benefits isn't known. And certainly the US Preventive Services Task Force has said that they don't recommend this product for smoking cessation. And the latest guidance from the RACGP is to say that you need to use approved products first. You need to walk people through that, and that you should only be using these products where someone has really gone through all of that. The other thing that the RACGP guidelines has said is that this is an unregistered product, so it is valid and reasonable for a medical practitioner to choose not to prescribe it. And so that's obviously within their comfort zone about what they want to be doing. It is a prescriber choice. it is really important that use is for smoking cessation only, because they're not, the harms really do outweigh any sort of potential benefit for people who are not smokers. The other thing to think about is the context. So if people have children at home or they're at risk of self-harm, then you particularly want to avoid the high concentration products, and you particularly want to avoid anything where they're going to be diluting things at home, because you know, in the case of baby J, that wouldn't have been avoided if there was childproof packaging, because actually the person was in the middle of making the product and they'd left the lid off. So the first thing to reduce those kind of poisoning risks, and also to reduce the risks of toxicity from kind of inhaling too much, is to limit the concentrations to less than 20 milligrams per mil. And that's also where the evidence is. So the evidence is about free base, in the trials, it's about free base nicotine, and it's at those concentrations of less than 20 milligrams per mil. As I've said, you really want to avoid at-home dilution and other sort of preparations. So the pods and the cartridges are called, and devices which have cartridges are called closed systems, because they actually mean you're not pouring the liquids out. The other option is, if you are doing, if someone is using a thing where they have to pour the liquid in, they can buy the ready-to-vape e-liquids that are already pre-mixed. And I think we do need to do more work about how to make sure that those are really child safe. The other thing is to limit the volumes of e-liquid given to the person, so that if a child were to swallow it, that it would be unlikely to be fatal. The other thing is to avoid flavourings that are likely to appeal to children, adolescents and non-smokers. So Finland only allows tobacco-flavoured e-liquids, and Canada is in the process of limiting flavours to tobacco and menthol. People have criticised that actually, because mint and menthol are very popular with children. So limiting the flavours to tobacco, or actually having them unflavoured for smoking cessation, is one option. It's really important to consider diversion, and to consider whether someone's doing doctor shopping to get the prescriptions, and that they might be giving it to other people, or they might be selling it. And it's difficult in this circumstance because there's no real-time monitoring. So if you think about other drugs of addiction, there's monitoring of whether people are going to multiple doctors or not. In this situation, it's difficult to know what to do about that. As I've said, it is better to have the prescriptions filled through a community pharmacy rather than people ordering them online through the personal importation scheme, because you have better assurance that that they're actually going to be properly labelled, that they're going to also have childproof packaging. One thing it's important to note is that the warning labels on the liquids, at the moment, the TGA required warning labels say, keep out of reach of children, avoid contact with skin, and avoid contact with eyes. So they don't mandate that, they don't require that people write, don't drink it. So that may come through the pharmacies. I don't know what the workaround is going to be there, but it's really important that when these are being prescribed, that people are warned that this is really quite a toxic substance if people drink it. It's also important, if it is being prescribed, that there's regular monitoring and follow-up. So the dual use is not quitting, and cutting down is not quitting. The other thing is that it's currently illegal for anyone under 18 to use e-cigarettes. So prescribing to adolescents is probably going to, isn't within that law. And I think there's also issues with prescribing in pregnancy, because we don't really know what it does in terms of the developing baby. So I think the other thing is to also consider, and I think Nutshell in their webinar, which is freely available, did talk about some case studies, and I think that that's the kind of thing that can really help to support practitioners to say, well, in the situation where you've got someone very advanced chronic obstructive pulmonary disease, who needs to be on home oxygen but is having real trouble actually just quitting, then you could consider if that person could totally switch, that might be an option. If someone comes in and isn't a smoker or is not in that kind of category and is just thinking of giving it a go and hasn't been through the other options, then it may be better to say, well, why don't we actually try some other smoking cessation options. The other thing to bear in mind is that these closed systems, the cartridges and the pods, are really expensive. So you're talking about sort of $70 a week or more if you're actually talking about the products that are available through the pharmacy. So people may be drawn to those. You may need to also think about what you can provide that's going to be free. For example, the nicotine replacement therapy that's done with PBS. So there's all sorts of conversations to have, and it's, it's obviously not my main area, but I think it's something where the different groups can and the different organisations can really help with coming up with guidance for their practitioners and their health professionals. So that's the end of my talk. I'll just, and I'm looking forward to answering any questions people might have after Raglan's spoken.
Thanks, Emily. And also good to see some comments and conversation happening in the site. I think, as Emily has really nicely articulated, it's a complex space, but it's always useful to understand what's happening on the field. And so I appreciate the comments in the site. I'll just share my screen. Is that working all right? Can you see my screen?
Yeah, we can see your screen, but we can also see, oh yeah, there we go.
Oh, good. Yeah. Could see my notes. Thanks, Marina, and thanks, Emily. Before I begin, I also just wanted to acknowledge and pay my respect to the traditional owners of the land on which we all meet. I'm coming in just down the road from Emily, actually, on the Gambri country. And so I wanted to pay my respect to elders, past and present, and also to Aboriginal and Torres Strait Islander peoples on the call today, and my Indigenous siblings across the seas. I also actually just wanted to acknowledge and pay my respect to Professor Tom Calmer, actually, as Marina acknowledged earlier in the call as a way of doing sorry business, and also pay my respect to their family, particularly Heather Calmer as well, and the family for all the work that they do, not just in tobacco, but everything that they do for communities. And my thoughts and best wishes are with them today. I'm Raglan Maddox. I come from the Modowa clan in Papua New Guinea. I sometimes stick this up, this image. There's a couple of photos here, a couple of images. The one at the back, I guess, is a 1975 map of Papua New Guinea and Australia when PNG was pre-independence. And then the photo at the top right is a photo of my uncle and my mother at boarding school. My mum is the one with the blue circle, and then my uncle's the one on the right. And my mum's lived in Australia since about 1980. And I found out through the COVID process, I was doing some paperwork for her, and she has three birthdays on different government bits of registration. And I guess the last one, I didn't know she had three. I knew she had two, but the third one got me by surprise. So I was filling out some paperwork, and I didn't get the birthday right, which is kind of embarrassing for. I'll claim being the favourite son. I'm probably not the favourite son if you ask my mother, but to not get the birthday right is a bit embarrassing. But it actually spoke to me about the challenges in accessing healthcare or accessing things like a COVID vaccine and things like that. And so I just wanted to acknowledge that those challenges we see through the role of colonisation, and those ongoing challenges can be incredibly difficult. And I guess Emily spoke about the role of prescription in this instance, and I guess the challenges and opportunities that we have that have come into play today. So I wanted to acknowledge that. And then also, I guess, discussion around COVID borders and other things. I stick in a little photo the wharf where my sister renewed her vows recently, just to remind us that we'll be able to travel at some point in the future. And I encourage you to get somewhere tropical and enjoy the scuba diving and snorkeling. So that's me in the context. I think Emily really nailed down on some of the challenges. I guess I wanted to come back to a bit of a population level consideration and to acknowledge and celebrate some of the successes we've seen in Indigenous tobacco control, specifically Aboriginal and Torres Strait Islander tobacco control. And so I just wanted to highlight this, that we have seen tremendous declines in tobacco use over the last 15 years. So we've seen about a 10% decline in daily prevalence among males and females. And you can see that's a pretty consistent decline. And that comes with context. And so I did want to just take a step back and look at colonisation and the role colonisation's played with tobacco use. And now as we start to talk about e-cigarettes and vaping and ENDs and NVPs and what's can be quite a complicated conversation, as Emily has articulated in an incredibly clear and concise manner. I think it's a lot of research and other challenges to articulate such a complicated but also not complicated issue so nicely. And so I did want to just reflect on that. So I sort of got here from 60,000 years up until today. And I think it's worth acknowledging that, you know, tobacco came through the oceans and was used as a commodity and commercialised. And then Indigenous peoples were engaged with the economy throughout the Pacific and then to Australia through the use of tobacco. And then Aboriginal and Torres Strait Islander people have been paid in rations of tobacco up until the 60s, which has embedded and entrenched tobacco use, which is one of the reasons why we see those incredibly high, well, relatively high prevalence. If you think about it in other ways, I guess if you entrench something and pay people in rations of tobacco up until the 60s, the prevalence is relatively low. And Emily also outlined how addictive nicotine is. So given we're up against an industry that promotes an addictive substance, 40% smoking prevalence isn't too bad, but obviously some significant room for improvement. I also wanted to highlight, and this is something Tom wanted me to talk about today. There's an image on the bottom left-hand side from Philip Morris International to AMSs around Australia that went out in around 2019. And it highlights a study on the safety profile of e-cigarettes. And so when we're talking about this conversation, it's not necessarily a conversation without commercial or vested interests. And so I think it's really important to acknowledge that because there is an industry and there are people that are promoting products and pushing products onto people at the expense of health and well-being. And so I'd really encourage you, and Tom asked me to make sure that when we are looking at information and we're looking at evidence, that we understand where that evidence is coming from. He also asked me to talk about that in the COVID response as well. As we talk about vaccines and other challenges, there's a lot of information, evidence, and evidence portrayed in certain lights that can be misleading, which we've seen through vaccine rollouts, but we have seen also, particularly in the last week, I've seen a lot in the media where the conversation hasn't necessarily been a sovereign conversation or a conversation free from those vested interests. And I think that's really important to acknowledge. And I encourage you, when you are looking at the evidence and the evidence that Emily has presented so nicely today, is it's important to acknowledge where it comes from and what implications that has and what bias is associated. So hopefully that makes sense. And then we have seen those significant declines in tobacco use over the last 15 years. I'll try and be relatively quick so that I know there's lots of questions that are brewing. I can see the chat box tinkering away. I think it's also important to recognise the Aboriginal and Torres Strait Islander population is incredibly young. We have a population that's about 50% are under the age of 30. And, you know, a significant proportion of those people are under 18 or under 15 as well. And with that comes challenge, but also incredible opportunities. I mentioned the decline in tobacco use, and we have seen that. And these two figures show the incredible decline, particularly among youth and young people. So you can see 18 to 24-year-olds, you can see a significant decline to about 30% in 2018-19. And you can see that across most of those age groups. But given that the population is a young population, it's really important to consider. I do have both urban and regional together, and then obviously remote conversation. And the conversation is different, the context is different. The access to different infrastructure is incredibly different across Australia. And I guess I wanted to acknowledge the diversity of Aboriginal and Torres Strait Islander people around Australia, but also within those communities. So while we're summarising the evidence, I appreciate that there is diversity and that the landscape within your community will be different as well and needs to be considered. The other thing I wanted to acknowledge and recognise is the vast majority of Aboriginal and Torres Strait Islander people that quit smoking unaided. And so I think it's important not to underestimate that. The other thing I wanted to sort of mention and see as an opportunity is, and Emily mentioned the RACGP guidelines and I guess moving to this prescription model, is that if people are looking to get access to vaping products, then they will be seeing a medical practitioner. And that gives us an opportunity to ensure that that person is aware of and has access to evidence-based cessation treatments and has access to supports, has access to quit lines and other things. So while there are challenges and implications and the messages can be complicated, ideally we will have people going to see the doctor about smoking and reducing smoking. And as Emily said, ideally quitting. There's also some evidence coming out of Dr. Michelle Kennedy's research team around, I guess, trying to move from the reducing conversation, but actually if doctors have a conversation where they're asking client to quit, actually we see benefits and sustained quit attempts as opposed to if we sort of beat around the bush and ask people to reduce tobacco use. We don't necessarily see the same sustained outcomes. So I think it's really important not to beat around the bush and to have the conversation about quitting and not necessarily just cutting back or reducing tobacco use. And Emily also, God, I'm just repeating Emily's conversation here, but Emily did talk about that even people that aren't smoking a lot of tobacco, the health harms are still there. And so I really just want to reiterate, particularly for health professionals and clinicians, that the conversation needs to be about quitting. Emily also talked about around, I guess, harm substitution and transitioning harm. And so the other thing that Tom and I spoke about last night was one of his messages was around looking at e-cigarettes as the product themselves and not necessarily comparing them to a tobacco product, because as we've discussed earlier, there is a challenge where we end up minimising the harms of e-cigarettes as well as minimising or distracting ourselves from the conversation about tobacco. And actually, if you think about it, and if you think about pre-contact and things like that, we didn't necessarily have, as Indigenous peoples from the Wattle Clan and PNG, we didn't have e-cigarettes, or we didn't have commercialised, commodified tobacco products, and we didn't necessarily have vaping products. So from a population perspective, these are ongoing challenges that we need to address on our own terms. And so I think that's really important. And to give us plenty of time for some comments and questions, I think we've got about 15 minutes left or 10 minutes for questions. I did just want to highlight that we have seen those significant reductions using evidence-based tobacco control programs and policies. And we have seen a 10% reduction in daily smoking and about 50,000 fewer daily smokers today than there would be if rates stayed the same in 2004-05. So there have been many, many lives saved, the vast majority of quit cold turkey. And obviously preventing uptake is incredibly important. It's really important that we stick to those evidence-based discussions and are really clear with our communications. And I think the other thing I just wanted to draw your attention to is that even websites like the Altria website, which is the parent company of Philip Morris International, explicitly talk about the epidemic of youth vaping and the role that vaping is taking, is sort of growing among youth and young people, and the role that it's taking in being a gateway to increasing tobacco use. So I guess in that broader population perspective, it's incredibly important to consider that. But we do have this opportunity where hopefully we'll see people going to the doctor to seek smoking cessation advice, and I guess entering a system looking for support to quit. So I'll wrap it up there, and I think we've got a few questions. I can see a bunch of questions coming in, but I'll pass it back over to you, Marina, and thanks for your time.
Thanks, Raglan and Emily, really like incredible presentations. And yes, there is quite a few questions I can see coming in here. A very easy one is, can we have copies of the slides, which if you're happy for me to share those with participants.
Yes, that's fine. Yes.
Yeah, perfect. Now, Kate Green said, I understand that it is common for vaping products that are labelled as nicotine-free to actually contain nicotine. What is being done to address this?
So this is a common problem, and it's not just that some are labelled nicotine-free and contain nicotine, it's also that the concentrations are often wrong. So I think this is part of the move to really have things more regulated, and particularly to have them supplied through pharmacies, because in that case you will know what the concentration is. And but I think in the community it's a big problem, and I think yeah, there are reports that kids using them don't actually know they've got nicotine in them at all. I'm also having reports that kids are using them knowing full well they've got nicotine in them, and they're actually seeking the sort of sensation of the nicotine. So I think both those things are happening. I do think the move by the TGA to make it illegal to have e-cigarettes, nicotine e-cigarettes, is part of trying to crack down on that. But I think what you can see from the chat is it's going to really depend a lot on the enforcement of that as well. I do think there needs to be a bit of information out there. I don't think we need full education campaigns, because we don't really want everyone knowing, you know, how to get them and things. But I think we do need for people to understand that it is illegal to possess them and to use them. It's not just about selling and buying. That is illegal now. And also that these things are highly addictive and that there are health risks. They're not harmless. I think sometimes there's good evidence that if something's sort of fruit flavoured, people often will then think it's less harmful somehow. Or if they can get hold of it easily, they think it's not harmful. So you see teenagers saying that, well, if it's so harmful, how come I can get hold of it so easily? So I think we need to make sure that this is part of a broader sort of framework approach, where we're actually enforcing, making it much less able to be accessed, as well as making sure that we're supporting people to quit. The other thing that we are seeing is people needing to quit e-cigarettes. So that's another thing that may come to practitioners, is that these are highly addictive, and people think that they can quit anytime they want, and then they can actually have problems quitting. So there's not a lot of information about how best to do that, and that's something that I think would be really useful to develop and give attention to.
Thanks, Emily. Is there training being provided to GPs with this new regulation we're aware of?
So I think it's really, I think the chair of the committee that did the RSCGP guidelines said that we are all going to have to be patient here. I think those materials do need to be developed. And I know that there was initially proposed an investment for the RSCGP to help, to create education products, but that actually wasn't being funded. So I think it's a really important area. I think GPs do need to have support and training for this. I mean, bearing in mind that it is an unregistered product, and we don't tend to sort of, in other areas, we don't go, oh, well, your blood pressure is not being controlled by X, Y, or Z, let's try a completely unregistered product, or, that doesn't seem to fix your thyroid problem, let's try something completely unregistered. So I think it is also a difficult time, and the hope, and I'm told hope is not a strategy, but the hope is that there will actually be registered products over time. Because the other thing to bear in mind is that these companies have been saying for a very long time, this is a great way to quit smoking, but they haven't actually applied to have them as registered products. So, if they are so great, then they should be able to do the trials and show the evidence and show they're safe, and then actually have them as products that are there for smoking cessation as registered products. So that's another complexity, I think.
Yeah, and that sort of, I guess, may apply also to this question where it says how do GPs get registered to prescribe through community pharmacies?
So I think so GPs can apply to be authorised prescribers. So that's what they'll need to do if they want to prescribe. They need to apply to be authorised prescribers. That's a fairly straightforward process through the TGA. You can look that up. You don't register with a community pharmacy, but there's some information in the RSUGP guidelines that you as a GP, if you prescribe the e-cigarettes, you can't really dictate to the patient where they get it from. But you can, if you know your community pharmacy, you could potentially send the prescription to that pharmacy and say to the patient, you can pick it up from that pharmacy. So there are sort of practical ways that you can link with your community pharmacy for that to be the source of it. But for the patient, they actually do have a choice where they get their prescription filled. And the person importation scheme is a legitimate way to get it filled. So, but I think knowing how skilled and sort of pragmatic primary care people are out there, and I really salute you in everything you do, I'm sure that there will be solutions that you can find for your organisations.
Thanks, Emily. I got a question here from Damian. So the company Jules was recently fined $40,000 for e-cigarettes targeting youth. Can we explore government looking at the targeting practices of e-cigarette companies?
So this is, I think, one of the really big areas is that e-cigarettes are being very heavily marketed to young people, particularly through social media and influencers. And there is work actively underway to look at that and to regulate it more. So we're kind of back in the dark ages in a way of how tobacco was heavily marketed before. And it's a bit harder to control because social media is harder to control in that way. But that is certainly something people are very actively working on. And I think it is really important that we make sure that that our youth are getting the right information here. Nobody wants to grow up with an addiction problem. Nobody wants to grow up with problems with their attention span and the kinds of effects that nicotine can have on the brain, including memory issues and actually kind of being wired for addiction. Like, nobody wants that. But I think there's a problem with really a lack of awareness of that, and this idea that everybody's doing it and it smells like bubblegum. I know that when my daughter goes to the same school that I went to, I know lack of imagination there. But anyway, when I used to go to the loo at school, it used to be make the nerds smoke, and people would try and make me smoke when I went to the loo. And now my daughter says it just smells like bubblegum or peaches and cream or whatever. It's just full of vape stuff. So it is really embedded in the culture of schools now, and it's something that we really need to work actively to tip the balance the other way.
I'll just jump in there as well, and thanks for the question, Damian. I think it is incredibly important to make sure that we keep having that conversation, because I know, or as you probably know, doing work across the country, one of the places where it always comes up is schools and principals at schools saying, what do we do? How do we address it? How do we have this conversation? And if we go back to just thinking about it being prescribed as a last resort cessation support, then it's unlikely that those youth and young people, and this is one of the reasons why I try to highlight those trends in non-uptake and that really encouraging work that's been undertaken. We have an opportunity here where we need to make sure that it doesn't get out of control. That's the other reason I sort of wanted to bring up the work coming out of Altria and the tobacco company saying we are seeing this epidemic occurring where youth and young people are taking up smoking in schools and at an incredibly young age, including at primary schools. So yeah, there is this misperception, and I guess that's why I wanted to highlight also making sure wherever you get your information from is credible. because the industry is promoting this product, and there is conversation about, you know, gummy bear flavoured products and nacho cheese and literally hundreds of thousands of flavours coming out. And then also the perception that inhaling this vapour or water is safe. And so that's where we sometimes see the conflation, and Emily talked about this as well. Just because a product might be safe to eat doesn't necessarily mean it's safe to suck on a pen and inhale vapour. A bit like, you know, broccoli might be great, but if you inject it in your veins, it's not going to be good. So, so just be careful of that, and I guess just think about that as well.
Marina, I could just whip through some of the questions, just very factual questions.
Yeah, I was actually just thinking we're slowly running out of time. So, I just wanted to say, I don't know if I said we're fined 40,000, did I? But I meant to say 40 million. I just had Damian say, no, I think it was 40 million. So.
That'd be not a problem, 40,000. So doctors are able to prescribe the closed devices like pods and jewels, and they're also able to prescribe the nicotine-free based liquid. There are new Medicare items for cessation. They include face-to-face and telehealth and phone items. I agree. I think everyone agrees this is about cessation of nicotine and not just smoking. So when we talk about the potential benefits, there's one group that may benefit out of this huge group of people, and that's people who switch entirely from smoking to e-cigarettes, but also who then might, you know, over time stop using the e-cigarettes. But I think what we're talking about here is, you know, 89, or it's a huge proportion of the population, particularly the young population, are not smokers at all. So we need to make sure that we're avoiding that use. The GP does prescribe, and then the product can be brought in under personal importation or through the pharmacy. And vape stores are not allowed to stock nicotine vapes. This is only going to be available through the pharmacy or the personal importation scheme. So I think the question about harm minimisation, I tend to not use that term. I tend to just use the word substitution, because there are so many unknowns, and it won't be harm minimisation if your child is poisoned. So you have to, I think it's good to say substitution, and I think that is an open question. And that's really going to be up to the individual doctor to say, well, is this going to make things better for this patient? Bearing in mind that most people go on to have dual use. So you need to be also supporting people to make that switch entirely. Concerns about passive vaping, we actually, there is evidence that e-cigarettes do cause increased particulate matter indoors. So there is an issue with potentially inhaling that. And then more information about pregnancy, well, it's just really unknown, and the current recommendations of the guidelines are to just completely avoid their use in pregnancy.
Just have maybe two more questions, because there's still so many coming through. Do you know what the penalty is for buying non-prescribed vapes from a corner store?
So the current penalty is up to $220,000 for having e-cigarettes. I think you have to, I'm not a legal expert, but I don't think that will be, I don't think that will be the kind of thing that will be levelled on individuals, but I think it's much more about, and their fines can go up to millions for companies that supply them. So, but I personally don't know what's going to happen to individuals who are found to be using vapes. And I think it is an issue about criminalising people, and I know that that's something which, especially in a situation where lots of people are doing it, if something's criminalised, it is then used to target particular people, so or groups of people. So I think we, you know, as communities, we have to watch out for how that's being enforced and how people are being supported through that process. But I think, yeah, the fines can be very large, and that's particularly for targeting companies that are permitting. Because what I hear from kids, and I know that the people around this audience know this better than me, but they're really freely available under the counter in convenience shops, in servos, in, you know, lots of different places, and there's and my hat's off to the people who are really doing some of this enforcement. I think it's you know, we've now got the legal basis to do that.
Mm. We might wrap up there. So thank you for everyone who sent in your questions and for attending today. And also thanks Raglan and Emily for your presentations. They were so great, and we really appreciate your time and knowledge and sharing all of that information with us. So thanks everyone, and have a great rest of the day and weekend.
So thank you so much, everybody, and I absolutely salute your brilliant work with community. You know, you really are absolutely incredible, and it's a privilege to be talking to you.
Thanks, everyone.
Thank you, guys. See you later.